السلام عليكم. بسم الله والصلاة والسلام على رسول الله وعلى آله وصحبه وسلم. First of all, I would like to thank and congratulate Dr. Hisham Tawakkul and Dr. Dua al-Nasri for the organization of such an interesting conference. I have followed the virtual meetings as well as the physical meetings, and although it's not my specialty, I was really interested. It was such an interesting conference and very recognized speakers. So thank you for that and good luck, inshallah. The title of my talk actually has been a point of debate till yesterday night. So I didn't know how to introduce the palliative care in the NICU. So I realized after attending the virtual meetings and the physical meetings that I will start by saying a step outside the box, because all I've heard is your tremendous effort, invasive techniques to help the child overcome the period of neonatal birth. But in my talk, I will actually concentrate on newborns, babies with life-limiting condition. Whether we know this life-limiting condition before birth or at birth. And this is why I consider it a step outside of an invasive trial to save the baby. And also a missed opportunity, definitely a missed opportunity, because in the whole Gulf region and the Middle East, as of today, we have no formal palliative care service in the neonatal ICU. Of course, I have no conflict of interest, and the objectives are as such. Of course, I will try during this half hour to convince you at the end that we need a palliative care service in the NICU. And also, I will try my best to put for you a quality improvement project proposal. If you like it and if you agree about it, then we can start implementing it anywhere in the Gulf region. So first of all, the definition of palliative care in neonates is different from that in adults. So the NHS has actually defined palliative care for the neonates as with life-limiting condition as an active and total approach to care for the neonate from the point of diagnosis or recognition of a life-limiting condition to death and beyond death as well with the family. It embraces, of course, multiple aspects of care, because palliative care is not only physical care, it is also psychological care, social care, and spiritual care. All of them aim at improving the quality of life of the newborn and of his family, and includes the management of symptoms, physical symptoms, and the provision of support throughout death and post-death also. As for the adults, the Center for Advanced Palliative Care, the CAPS, has a straight definition that palliative care is a specialized form of medical care for people living with life-limiting illness, such as cancer, of course, where I work, or non-cancer, COPD and heart failure and so on. And this type of care is focused on providing relief of the physical symptoms, the stress of the illness, and the same also, it will imply physical, psychological, spiritual, and social aspects of care. It is based on the needs of the patient and not on his wish. And it is appropriate to be used at any stage of the disease. So in cancer, for instance, when we have a young patient who comes to my clinic with a diagnosis of glioblastoma multiforme, grade 4 astrocytoma, which is not surgically resectable, we should integrate ourselves from the beginning, because we know from the prognosis that GBM without resection, the median survival will lie between 6 and 9 months. So we have to be integrated with the primary team. So what are the models of palliative care in the neonatal care? Of course, palliative care can be initiated ideally in the prenatal period, especially with the continuous progress in the prenatal diagnosis of life-limiting conditions. And it can be also introduced at the time of delivery if the condition is diagnosed at the time of delivery. But most commonly, in most of the hospitals, the introduction of palliative care is in the form of a consultation service initiated by the neonatologist, taking care of the baby and his family. And this is what we call a combined care model. What about the history of palliative care in NICU? Well, I was surprised actually to know that palliative, the first introduction of a specialized palliative care service in NICU was in 1980, and that was in England and North America. And of course, the need for a multidisciplinary approach discussing end of life or post-death bereavement and grief is very known, especially in neonates with life-limiting conditions. And palliative care has progressed over the past 30 years, at the same pace of progress in neonatal care. It is always better to engage palliative care as early as possible. And this is what we have been saying, especially in the prenatal period. With fetal diagnostic management and the development of genomic medicine and all the coming future. What is the magnitude of the problem in terms of life-limiting conditions in neonates? We have here a term that all of you probably are familiar with, which is the infant mortality rate. It is defined as the number of infants who die before reaching 1 year of age for every 1,000 live births. It is an important marker of overall health of a society. And the IMR in Qatar in 2021 was 5.8 deaths per 1,000 live births, with a decline from the previous year. And also, we must say that the IMR in Qatar is slightly higher than that in the US. It's 5.6 versus 5.2, I think. What are the most common causes of death in the NICU? In Africa, the proportion of facility-based neonatal mortality was around 20%. Preterm birth is the commonest cause of death in the NICU, reaching about 29%, followed by birth asphyxia, 22%, infection, 18%, meconium aspiration syndrome, respiratory distress syndrome, and congenital anomalies. What are the predictors of death in the NICU? Of course, low birth weight, and we define it as a birth weight less than 2.5 kilogram, preterm birth, length of stay in the NICU, and a low 1 as well as 5 minutes upper score, hyperthermia and delayed initiation of feeding, and of course, infections. So what are the characteristics of palliative care engagement in the NICU? This is an international definition of where to put palliative care. Palliative care should be only considered if the baby has a life-limiting condition through a joint individualized decision between the neonatal team at first, the parents, and the palliative care team. So we have 3 stakeholders here. So what are the aspects of palliative care in the neonatal ICU? First of all, to establish the eligibility of the baby for palliative care. Second, family care, of course. And third, and very important point actually, how to communicate and document end-of-life discussions, including do not attempt resuscitation decision. It should be a flexible parallel care planning, and the transition from active postnatal care to supportive care is an important point as well. And of course, end-of-life care, which will include the same physical, psychosocial, and spiritual aspects. So, you have to believe me that the communication of end-of-life discussions, including DNAR decision, is a very difficult task, and it needs training, and it needs to be follow a certain rule. And in fact, there was a very nice study recently about adults, which said that a palliative care physician should not undergo more than 3 end-of-life discussions per day. Unfortunately, we cannot accomplish that in Qatar, in the National Cancer Center, because we have 300 new patients per month. So we cannot do that, but it is ideal to be a bit limited. So it follows the spikes technique. In order just to remember, S stands for the scene. We cannot do such a discussion in the corridor. So we have to set up the scene. We have to close the mobile phones and prepare. And the P stands for permission from the parents to discuss end-of-life issues. And then let them invite any other members from the family or the friends that they would like them to attend. The I is for provision of all possible information about the newborn. So you have to go in while you know all the lab results, recent lab results, and radiology results concerning the newborn. The E is empathize with the family. So how much can a palliative care physician or a neonatologist empathize with the family of a dying baby? There has been a paper actually on this issue. We are humans, so we have also feelings, and we are allowed to empathize. This was the conclusion of the paper, but not to get too much involved with the emotional, feelings that are present in this meeting. In other words, you are allowed to cry, of course, but try to, as much as possible, to be governing the discussion, and then later on maybe you can. But of course, you will empathize with the patient's family. And S at the end is to summarize at the end of the discussion that the family understands everything, and don't leave the family without setting up a goal. Even a very short, to some people, meaningless goal, it would be a very meaningful for the family. For example, going to the garden with the newborn, it's a goal, simple, but it means a lot for the family and for yourself as well, for the team. What are the main physical symptoms in newborn with life-limiting conditions that present and I would say probably would need a specialized palliative care intervention? Pain, restlessness and agitation, seizures, increased chest secretions, dyspnea, and shortness of breath. Of course, these are the main symptoms, but we can also find others. So what are the life-limiting conditions in newborns? Of course, I am standing in front of all the NICU consultants, and I'm trying my best to summarize what I have been reading for the last 3 to 4 weeks. So prematurity, asphyxia at birth, gestational age less than 32, low birth weight less than 1 gram, and a low Apgar score, 5-minute Apgar score, perinatal asphyxia, congenital infection, maternal fever in labor, and others, anencephaly and renal agenesis. Okay, this slide is important because I think we have to differentiate between the role of palliative care in neonates versus adults. So in neonates, we know that it is difficult to assess physical symptoms, such as pain. On the other hand, it's easier to assess pain in adults. And by adults, I mean all patients above 14 years of age. This is what we follow in our hospital. So it's more easy to illustrate and also enumerate and give a percentage of for the pain that is present, and also the type and the quality of the pain. The main physical symptoms in neonates, as we said before, with life-limiting condition and in an end-of-life situation, would be pain, agitation or restlessness, and increased chest secretions. While in the adults, we have the Edmonton Scale Assessment Score from Canada, and this includes the most common 9 physical symptoms that we score each one of them from 0 to 10, and we also ask about the quality and so on. The support in neonatal care is definitely more for the families, but it is at least as important for the family as for the neonate. While in adults, the support is focused on the patient and his caregivers, could be direct family members or friends or others, next of kin. The bigger role in neonatal palliative care actually is grief and bereavement post-death. The situation of a dying baby is much more difficult than the situation of a dying elderly person with a long-standing prostate cancer, which is metastatic, for instance. The psychological and the spiritual support, and this is very important, psychological and spiritual support have a much higher role than physical support in neonates, in the family members, of course. And I have to stress here that spiritual support is actually underdiagnosed and underscored and also undertreated, because when you say spirituality, it's a broad term and nobody can really define spirituality. But there are many, of course, studies in this issue. So those are the main differences between neonate and adults. I will come here briefly to the UAE experience in neonatal care, and you can correct me, of course, at any point. And I have been trying to gather as much as possible information from Al-Qurnish Hospital and other hospitals. So the outcome of low birth babies in Abu Dhabi has improved in the last, can I get rid of this? Excuse me. There is, can I get rid of this? There is something on the right which prevents me from, anyway, I can read from here. Has improved over the years and is similar now to that of developed countries. The current incidence of low birth weight at delivery is around 9% compared to 15% in 1995 across all Emirates. The neonatal mortality rate is reported as 6.9 per 1,000 live births, with prematurity, preterm birth complications, and lethal chromosomal anomalies accounting for about 77% of all deaths. And consanguinity is present in about 50% of the cases. However, it did not decrease either the birth, it did not affect the birth weight or the prematurity. And I will try to touch on, of course, your well-recognized hospital, Al-Qurnish Hospital. It was opened in its current location in 1984 as one of the first maternity standalone hospitals in Abu Dhabi, and in fact, it is the largest maternity hospital now in the United Arab Emirates. The NICU, you can definitely correct me, Dr. Hisham, has 54 cots and well-staffed, 27 physicians, 110 nurses, 13 unit attendants, and 4 respiratory technicians, in addition to a satellite clinic that provides outpatient for low-risk newborns. They have 4 intensive care units with a total of 27 cots and 2 isolation rooms and 3 special care nurseries with 35 cots. Equipments for cooling, nitric oxide provision, and amplitude integrated EEG are also available. There are about 8,500 deliveries per year, and there are about 1,000 admissions to the NICU in Al-Cornish Hospital. About 200 neonates are less than 1.5 kilogram at birth weight, and the long-term plan usually takes place at the nearby Sheikh Khalifa Medical City, and there is also a community outpatient clinic for high-risk babies. Fetal medicine unit, there is a fetal medicine unit, IVF services, and most importantly, a postgraduate graduate education certified neonatology fellowship program. For Qatar, the total number of cases seen per year as of last year was 1,300 cases. And we have the Golden Hour program, which is adopted to provide multidisciplinary team resuscitation and stabilization within 1 hour from the delivery of a premature baby. And Hamad has already marked the World Prematurity Day to raise awareness of premature births and to provide support for families of the premature babies. We have about 100 premature babies per year with life-limiting conditions. And the neonatal mortality rate in Qatar was found to be 4.28 per 1,000 live births. The neonatal mortality rate has dropped from 6 over 1,000 live births in the year 2003 to 4.3 live births in the year of 2008, and that was from a publication. And mothers with diabetes have a specialized MDT multidisciplinary team antenatal diabetic care management approach to avoid increased birth weight. Quickly, through 2 papers that were published last year, one of them was addressing the socio-economic factors for hospital-based neonatal death. And the conclusion of the paper, they found that in-hospital neonatal death was more pronounced in uneducated mothers and in low-income mothers, mothers living in shared houses, consanguinity, and in mothers having no antenatal care or preterm birth. So those were the socio-economic factors that were studied. And the number, the neonatal death was 5.7 per 1,000. Now, another study, also in 2021 in PLOS in October, was studying the incidence and the risk factors of fetal-maternal outcome of inappropriate birth weight for gestational age. So this was a population-based retrospective study. It included around 15,000 live births between April 2017 to March 2018. And there were 2 groups, the small for gestational age or SGA, and the large for gestational age babies. There were in general higher in-hospital mortality for small for gestational age babies compared to large for gestational age babies, 2.5 versus 0.3%. Higher NICU admission and death in the labor room for small gestational age compared to large gestational age, and preterm babies were more likely to be born small for gestational age. What is the proposal that I'll come to the proposal of a quality improvement project to be, I will present it to the NICU. Of course, the title would probably be Early Introduction of Palliative Care in the Management of Neonates with Poor Prognosis and those with life-limiting conditions. And we will provide a holistic approach of care that will include the baby and their parents or caregivers, starting from the date of diagnosis till death and post-death to the parents. Palliative care engagement will actually cover physical, psychological, spiritual, and social aspects of care. We know that any palliative care team is a multidisciplinary team, and it includes physicians, clinical nurse specialists, social worker, psychologist, and spiritual advisor, also physical therapy. So at initial involvement in this project, the palliative care team, together with the primary neonatologist and the family of the neonate, shall meet to discuss the prognosis of the newborn and also how end-of-life care should be done, and put an advanced plan of care and answer any queries for the family of the newborn. The palliative care team will then arrange for at least 3 visits per week for the baby and the family, and it could be increased, of course, in case that the baby has a prognosis of few days or hours. And of course, the palliative care team will visit also the family, and there will be, at least in our hospital, a 24-hour, 7 days coverage for a palliative care physician. And in due time, there should be a discussion about the court status of the newborn in the presence of the palliative care team, neonatologist, and family of the newborn. What is the aim of this quality improvement project? Actually, the first aim is to properly address the non-physical aspects of care for the baby and for the family members, which are the psychosocial and spiritual aspects. And in fact, this can, of course, start from the beginning and extended till death. And one important issue also is to decrease aggressiveness of care at end of life, including unnecessary resuscitation, and to provide palliative care addressing grief and bereavement post-death. So we have the non-physical symptoms. We have to decrease the aggressiveness of care. If we know that the baby is going to die within a few days, then there will be no meaning to be more aggressive than that. And also to provide for the first time post-death that we do actually for adults. We do post-death grief and bereavement, and we follow them, the family members. Now I will talk a bit about so that is a bit of a summary of the quality improvement project. We can, of course, extend and write it and all of this, but this is the idea of involving palliative care in the NICU for the first time in the Gulf region. And this is already a few years back. I mean, it has been already implemented a few years back. Now, what is the immediate management of neonatal deliveries for newborns with life-limiting conditions? The end-of-life care varies between hours, days, and weeks for those patients, as you know. And the prognosis differs between newborn with unresolved respiratory asphyxia and those with anencephaly or renal agenesis. What I mean by that is that the newborns with unresolved respiratory asphyxia will have a prognosis of definitely less than renal agenesis, for example. And a good prenatal care is essential for a good post-birth end-of-life care, both for the neonate and the family. And as I said, a specialized multidisciplinary team of palliative care actually is an essential component in the NICU in North America and Europe, in addition to neonatology, of course, and patients' family members to assure a good end-of-life care for those neonates. A DNAR discussion should be addressed as soon as the baby is delivered and decision should be reached. So, DNAR stands for Do Not Attempt Resuscitation. We have done a study in Qatar comparing, and actually it was first initiated in a cardiology department in the US, where they found that the word do not contains a negative message. Do not attempt resuscitation. So they compared the word DNAR to the word A&D, allow natural death. And they found A&D is much more accepted by the family members and the patient compared to DNAR. موتة ربنا in Arabic. Allow natural death. So we are now changing our policy from a DNAR decision to an A&D decision. It is more accepted by, especially in our culture. Now I can skip this one. Okay. Psychological support for the family, including anticipatory grief and spiritual support. A simple definition of spirituality would be, why me? Or why me, God? Why did I have such a child? Or why did I have such a disease? This is one simple example of aspects of spirituality. We also have to look for reduction in vital signs, invasive monitoring, and phlebotomy and imaging tests. These are the things that we should avoid if we are sure and we have a confirmed diagnosis of a life-limiting condition. A compassionate withdrawal of life and supporting machines. This is probably the hardest decision that I ever encountered in adult patients. I was asked more than one time to participate in withdrawal of life support. And of course, it is a very sensitive decision. Prenatal diagnosis has to be well developed and able to reach the diagnosis and even set up the plan of care after delivery together with the family members. And of course, immediate full resuscitation for the following conditions: asphyxia, neonatal and premature delivery, 22 weeks, low birth weight and severe bradycardia, newborn with a known prenatal diagnosis of life-limited condition with poor prognosis will have the following in Qatar: tender loving care with the mother, which is to allow the mother to hold minutes, nutrition, either through nasogastric tube or IV fluid hydration, palliative care involvement to address physical and non-physical symptoms, and by physical heal, I mean, again, the most common pain, restlessness, and agitation, or increased chest secretions, and therapeutic hypothermia to cool the body temperature to 34.5 Celsius. Quickly, pain, very difficult to be assessed in neonates. The only thing that you can depend on probably are factors or vitals such as requirement of oxygen, or increased blood pressure, or increased heart rate, or by expression, grimace or no grimace, or by the sleeping pattern. Babies who have pain do not sleep. And I'll just give you an example of morphine usage in neonates. Morphine, of course, is the most common and the most accepted drug, first choice in adults as well as in neonates. And There are varying degrees of discomfort, stress, and pain that are either caused by the disease itself, such as necrotizing enterocolitis, epidermolysis bullosa, or by the invasive process during the patient care. And don't be surprised that this figure is true. The daily assessment of pain in neonates occurs only in 10% of the patients. I mean by that the comprehensive assessment, not only the scoring. Okay, and of course, some few issues about morphine. Of course, the dose is in microgram, and the starting dose is a 100 microgram per kg, infused over 1 hour, followed by a continuous IV infusion of 10, 20, or 30 microgram per hour, depending on the gestational age. And the good thing is that there are no clinically significant difference in mortality between newborns who received morphine infusion versus those who received placebo. And also no significant difference between the two groups in the incidence of intraventricular hemorrhage. I'm out into the, okay. No, I want to go back. I have only 2 slides. Back again. Okay. Summary. Palliative care engagement is highly needed in conjunction with the neonatal care, especially in the group of newborns with life-limiting conditions and poor prognosis. And this prognosis, as we said, could be hours, days, or weeks. And the aim of palliative care involvement in the NICU is to reach a holistic approach that would address physical and non-physical symptoms. And palliative care in conjunction with neonatal care is essential in end-of-life discussions, DNAR discussions, extubation decisions in the NICU. Next one. Palliative care, ideally, for neonates can start as early as the prenatal care, especially with the new development that have been progress that have been made in the neonatal diagnosis. And actually, it differs from adults. So palliative care in neonates is different than that for adults. And the improvement and value of palliative care involvement for the NICU can be tested through a quality improvement project, the one that I discussed with you. We can actually carry this project as a phase 2 cohort study. And we don't have to compare two groups if we don't have the large number. And finally, palliative care extends beyond death to the family members through bereavement and grief of the parents. Next. Future directions. I consider this a very important slide, actually. What are the future directions for palliative care engagement in neonatal care? First, given the improvement in the diagnostic capabilities, as we said, in fetal diagnostic and intervention centers and early engagement of the palliative care in the prenatal period should be one of our future goals. Second, the progress in genomic medicine expected to help in diagnosis of multiple anomalies and metabolic disorders would also support early engagement. Third, there is a possible, and this is very important, by the way, for all neonatologists, there is a possible chance to acquire one or two of your members that are interested in palliative care, so as to train them with specialized palliative care physicians to become, in the near future, local champions that can carry on palliative care with a more more specified way. So that is also one of our goals in Qatar, to train one of or two of the physicians, young physicians who want to, carry on palliative care in addition to neonatology. Next. And fourth, a big opportunity for research. If we are going to adopt a specialized palliative care in neonatal ICU, a research in, for example, symptom assessment and management, evaluating communication skills, help in end-of-life discussion, withdrawal of medically assisted nutrition and hydration, or ventilator withdrawal. And finally, this is my final goal, we would like at the end to reach a concurrent care model, especially for neonates with life-limiting illness. And this model will include first neonatologists, palliative care specialists, and the patient's family members. And thank you very much.